Here we go. There we are. We are live. We got a little Beyonce going. Check on it because we are joined by Dr. Heather Fraebel, FR, and sounds like or pronounced like Vrabel, Mike Vrabel. If anyone knows, the football coach of the Tennessee Titans. So Heather is joining us from. Are you in Boulder right now?
Yeah, I'm in Boulder, Colorado.
Yeah, so a stone's throw away from where I am in Superior, and you also come to the office here in Louisville, so a little closer to where we are. And we connected at my wife's book launch event, and obviously a lot of parallels over there between her work and then your work. And I'd love to hear and jump right into what you do, pelvic health, why we should be promoting it, what people need to know.
Yeah.
Cutting off Beyonce. Sorry, Beyonce.
Yeah, cool. So pelvic health physical therapy. I'd like to say it's more of a household term these days, but still a ton of people don't even know what that means. Basically, think physical therapists were the function and movement experts, looking at musculoskeletal and neuromuscular systems. And pelvic health just takes a greater focus on the pelvic floor. So we address men and women, any issue, any gender, and a wide range of issues, like prostate removal for men, for women, anything postpartum, diastasis, incontinence. I like to say if you have any issues peeing, pooping, or having sex, then you probably could benefit from a pelvic floor physical therapist. So that's the sum of it. And
Nice.
It's so much more than just Kegels, and
Yes.
we'll get to that, I'm sure, in the future.
Yeah. So, and just maybe give us a little bit of a maybe disclaimer. I like that elevator pitch for sure of any issues peeing, pooping, or having sex. But where does someone like Maha come in? At what time can folks think about or getting the psychological aspect? Is that something I know you're going to refer out if you see them? But when should they check one first versus the other kind of question?
Yeah, that's actually a tough question because it's kind of either or. Sometimes people are seeing someone like Maha or a mental health expert, and they get then referred to physical therapy when that person determines it's a physical issue going on. Mm-hmm. And then a lot vice versa. So I guess I do see a lot of people that come in for a physical issue. The further we dive into it, we realize there's some mental and emotional underpinnings, which I think the pelvic floor has more of that than any other body part or dysfunction in the body. So yeah, chicken or egg. I do refer a lot of people out for sure. And a lot of treatment in physical therapy is a little more mental, emotional. We do a lot of just like stress reduction, breathing, mindfulness, but
awesome. Yeah, the biopsychosocial model, especially when it comes to something like low back pain. When it's a knee pain or ankle injury, usually it's a little bit less there, but sometimes. But yeah, awesome. So again, talking about pelvic health, and I'll share this to the listeners here. When I was in physical therapy school back in my day, 2005 to 8, pelvic health and women's health was and it was only called women's health then. Is it now the term pelvic health?
Yeah, just like 2 years ago, finally changed to like the Academy of Pelvic Health is what the section is called, rather than women's health.
Women's health, yeah. And that's because men obviously have pelvises and have pelvic health issues as well that we don't want to ignore, and of course non-binary folks, all these different very interesting and again hopefully more talked about things. For sure. So, but when I was a student, I kind of, because the main thing is the women's health, I was like, this seems like something that needs to be more talked about and needs to be. And I very much considered going down that path. But I think logistically, it was just very tough as a man to go into that profession back then. I think it's a lot more acceptable now. But even now, you're still going to have issues with being one-on-one in a room. And even females need to be careful as a female provider. Just being one-on-one in a room doing very intimate kind of therapy. So any thoughts on that the emergence of that or any of that?
Yeah, I will say one thing that actually really got me into this area of physical therapy was, in PT school, I got one hour lecture in entire grad school about pelvic health. And I thought, like, yes, we do need to talk about this more, not just brush it off.
Mm-hmm.
And yeah, I think like because it started as women's health, it's even harder to raise awareness that men need this too. I will say I do have a friend that is a male involved in pelvic health PT, and he claims, I haven't looked at this, that he is like the only one in the state of Colorado that's a
Mm.
male pelvic health therapist. So it's very rare.
Yeah.
And yes, he is legally obligated to have a chaperone,
Mm-hmm.
yet I am not. So we
Mm.
still have a lot to work out in that sense.
Yeah.
And I do think we would benefit from more males in the field. Obviously, a male coming in for a pelvic health concern might be more comfortable with a man.
Right.
Um,
Yeah.
yeah.
So, and the other thing, let's take a big step back and define the pelvic floor, maybe for anyone
Mm.
not super associated with it or familiar with it. And for me, as a more orthopedic sports physical therapist and fitness guy, I think the way I talk about it is the top of the core. And again, it's interesting, and I wanted to go back to this because over 90% of folks are going to deal with some kind of core or low back thing going on. And so when you start talking about the core and some, I think it's again starting to make its way into the more mainstream of treatment, that the core is the top is your diaphragm, right, where your breathing muscle is the bottom of the rib cage. Flank steak, if anyone likes cows and eating meat, that's the flank steak, is the diaphragm
Mm.
of the cow. Fun fact. So and we like to think of it as like a Coke can or a can of soda or whatever. This is Spindrifts. We're not sponsored by them, but this pineapple flavor is delicious. If Spindrift wants to sponsor me, I know they sponsor Mike Birbiglia, I think. So anyway, his podcast, good podcast. So the core being top diaphragm, bottom of the core is the pelvic floor. And so when you're dealing with back stuff, a lot of times we tend to focus on, okay, let's get your core stronger. Let's get your abs stronger. Let's get you to better able to hold a plank, maybe even a side plank. But I think there's a lot in between and missing there. So that's a very, again, maybe overly orthopedic definition of it, but I'd love to hear how you talk about it and if I missed any major components.
Yeah, I like to explain it as that as well. That just highlights the importance, the pelvic floor being that bottom of the core. Because yeah, most don't ever address that when we're dealing with any kind of core retraining, and I see, and it was kind of cool. My career started with kind of a blend of pelvic health and orthopedics, and I started to see like my pelvic health knowledge was really helping me orthopedically, helping people with low back pain that wasn't improving with classic treatment. So I think it's underrated as a power source, like drawing power from your pelvic floor to support your core, or vice versa. If you're drawing too much stability and power from there can be dysfunction. But yeah, and in addition, I would say not looking at the pelvic floor as just a muscle, because it's so different than a lot of other muscle groups. Like it really encompasses like three different systems of our body. You have the urinary system, the reproductive system, because you've got an ovary or uterus or prostate in there, and then you've got the GI system. And all of those things, issues with those systems can be affecting pelvic floor, and pelvic floor musculature can be affecting those systems. So it's also not looking at it just as a muscle group, but how it's interacting with these other systems in the body.
I'm just going to define GI for folks in case
Yeah.
they don't know that one. Gastrointestinal, so basically digestive system is the overly
Mhm.
easy way, just in case anybody missed that. Sorry, go ahead.
Yeah. Yeah. No, that's it in a
Yeah.
nutshell.
Gotcha. Awesome. Well, again, so I think the question now becomes, what are the top three things we should know about pelvic health, whether we're male, female, again, non-binary, anything going on there that will help us prevent any kind of issues down there. B, and obviously we're trying to talk about it here and get the word out. So anything we can do there. But B is are there things we can be doing to prevent? And then if we do start having issues, how do we say, oh, this might be something I should go see a pelvic health? And obviously prevention is always worth an ounce of prevention is worth a pound of gold or pound of cure. Sorry, I messed that one up. But so there's the prevention side and then there's the treatment side. Obviously we want to keep pushing prevention, but if people do end up with the issue already, what are ways we can look out for that? And we can say, oh, like, I'm not going to go to my GP. I'm going to go right to my pelvic health specialist.
Yeah. So prevention and awareness, I think, is just like to everyone out there, do you know what your pelvic floor is? Can you like do anything with your pelvic floor right now? Can you contract it? Can you relax? If this is totally a void for you and you have no awareness of what tension you might be holding there right now, or how you're using it when you work out, that's a sign of like, okay, you're not doing anything to prevent a dysfunction. I wish, and how would people get this? In an ideal world, I don't know, maybe at your primary care visit, a physical therapist gives you a little evaluation, but I would love people to know and optimize how they're using their pelvic floor while they're working out, while they're on the toilet, and while they're having sex. And then, like, okay, when something goes wrong, I think, it's tough. Very few come directly to a physical therapist
Hmm.
because, okay, say you start having, constipation, you're going to go to primary care or GI, gastrointestinal specialist. Or if you're having urinary issues and urinary retention, you're often going to urologist first. Um, I wish everyone came to a physical therapist first for any, again, pooping,
Yeah.
peeing issue with sex, because I think even when you see those other specialists, there is some kind of muscular component that can be
Hmm.
addressed. And not a lot of doctors know enough about it to refer those people out to PT. But again, it's a tricky thing. Obviously,
Yeah.
something like a UTI, you're going first to a doctor for antibiotics.
Hmm.
So that's tough. It's different than, like, I would say, any other musculoskeletal issue. The second you have it, a
Hmm.
primary care is not the best person to go to for your back pain. A physical therapist is. But I understand that some of these pelvic dysfunctions, it's hard for an individual to parse out themselves. Is it a musculoskeletal issue or is it a medical issue?
Hmm.
So I can't necessarily say every single issue a physical therapist can treat, but we could at
Right.
least tell you when you needed to go elsewhere. And I will say, primary cares, they're great at what they do, but sometimes bringing up these issues, first off, people don't want to bring them up to their primary care. And
Hmm.
some get written off. Some people
Yeah.
that say sex is painful get a little written off by their doctor, or a
Mhm.
doctor doesn't have much to do for them.
Yeah.
That's where I think, like, regardless of the issue, whether it can be addressed by PT or not, if you go to a PT, you're going to get heard a little more.
Hmm. Hmm. So
Um,
yeah, I'm gonna come back to this is Bono stuff, and the reason I call it that is because I want to know more stuff, and so I'm gonna selfishly ask this question as an again orthopedic guy. When someone
mhm,
comes to me with back pain, hip pain, especially, I tend to ask those questions of like, are you having any of these issues? There's the any graduated physical therapy and passed the board exam knows that if you have numbness or anything down there, woo, that's a red flag. We gotta send you to the ER right now. But there's a lot in between, nothing going on or very, very minor things going on and nuanced things. So I guess my question is is this something we could push for of you got back pain, you got hip pain. I'm happy to help you on the musculoskeletal side on the let's get you stronger. Let's improve your movement patterns. Let's improve your breathing. Let's get you tapped into that. I'm far from what I would not say I'm a pelvic health specialist. So would it be beneficial to refer every person with back and hip pain to a pelvic health
mhm.
specialist, or are there going to be a little less, a little more, where there's better situations? So maybe for the orthopedics out there, of any kind, orthopedics, chiros, orthopedic surgeons, what message would you give us of when to refer? Is it only when there's an issue, or do you feel like there is a way we can get in there and again empower the person? Because an hour with you, I'm guessing, is worth decades worth of education that go miss. So an hour with you is a great investment, I imagine, in saying, oh, like now I understand a lot more and I know what to look out for now. And if I'm really prioritizing my health and investing in my health, what can we do? I think there was a question in there.
Yeah. And twofold of when to know, or I'm going to answer in kind of two parts: when to know when to send a pelvic physical therapy. I think first off, like, yes, asking these questions, like, and not just like the brief, like, any bowel or bladder changes, because I see a ton of people that just live life having what they think is normal. Like, I had one patient once, I was like, oh, are your bowel movements normal? And she said yes. And I said, how frequently are you going? And she said, once a week. So asking, like, how often are you peeing? How often are you pooping? And is sex uncomfortable, could be some better and less so basic questions. Um, So yeah, if there's any clear dysfunction that they're reporting, or sometimes I see a lot from orthopedic colleagues, it's like they start treating someone and it's like, whoa, they're telling me there's incontinence when we're doing this exercise. So obviously, if there's an actual dysfunction that arises or they volunteer and talk about, then send to pelvic PT. And then I would say not necessarily every low back, hip patient, but if they just aren't getting better or aren't progressing how you'd expect, that's when I would say, like maybe pelvic health would be something to look into. Oh, how often are you
Oh, that
peeing?
I just put that
Oh,
in just to kind of summarize the
yeah.
so we have that kind of notes.
But little blurb, like what are the answer to those? Peeing should be like once every three to
Mm.
4 hours, maybe once at night. Pooping once a day, and sex should never be painful. But yeah, I would love to see a world where all orthopedic PTs have a way to even just generally screen pelvic floor.
Mm.
Obviously, we're not asking them to do internal exams, but can you even cue someone on what they are doing with their pelvic floor during the exercises? Like you even sound a little more cued in than most. Like how are you using breath? When are you relaxing your pelvic floor versus contracting it? Um, and there's even really easy ways to like externally overclose, palpate a pelvic floor contraction.
Mhm.
So it'd be very easy to teach orthopedic PTs a little more about this so that those general patients that don't have any major dysfunction, you could make sure you're tapping into that underrated part of the core. But lofty goal, I know.
Yeah. And you said sex should never be painful. I'm going to go ahead and say there's plenty of people who disagree with you, without going
Well,
too far
true.
down that rabbit hole. But to the point that we're talking about, yes, for sure. But everything we just said does bring us to the common, I think, the big thing that a lot of people probably do know. And as you mentioned, we didn't use the song WAP as our intro song, but the word Kegels is mentioned. So that's a big one out in the world. So I can talk about what I think of as Kegels, how I talk about Kegels. And this is a controversial thing. For some people, it's not controversial. They just think they accept it. And so I'd love to. I know you got a few strong opinions on this, so let's jump into that. Throw it right back to you.
Yeah. So first off, I mean, the word Kegel was used 70 years ago, and by a man that was something that women should do. So I got a little bit with the origin of it in the first place. And then the other thing I don't like about the word itself is that it doesn't really give you any context of what it is. And they actually had a research study that found like over 40%, and I would venture to say even more than that, based on what I see, don't do Kegels properly, because it's not, again, why don't we just call it a pelvic floor contraction so that people know what they're doing? So I don't like the origin. I don't like the word itself. The other thing is that like it's great that this definitely has become a household term, but there's so much more than simply a contraction. Like every other muscle group, the pelvic floor needs to be worked on with endurance and also with like quick contractions. So it needs more than just a Kegel. And that's where like I had one woman once come in telling me she was doing 300 Kegels a day and why was she still leaking?
Mm.
And I asked her to see how long she could hold a contraction, and she could only hold it like 3 seconds, whereas we want someone to hold it for about 10. So it doesn't, describe the other realms of strengthening women need. And I think people just write off all of pelvic health as Kegels, when in
Hmm.
reality, like here we are talking about how it's just a piece of that core. And as pelvic floor physical therapists are good pelvic floor physical therapists, I will say there are some out there that still just believe in pelvic floor contractions, but we really look at the whole system. We're looking at their abdomen, their low back, their hips, how all of that is playing and working with the pelvic floor. So I see a lot of people that, again, because of the reign of Kegel, they've just written off like, I don't need pelvic PT because I've already tried Kegels. So again, it was, in a way, I'm appreciative of Kegel for starting the conversation and getting people talking about their pelvic floors a little bit. But I think it's time to do away with the Kegel. And I don't know. There's not one
Improve it,
thing to
evolve
replace
it.
it.
Is
But
that's what you're challenging? Is it the evolution of the Kegel? You say that?
yeah, yeah.
Yeah. So I'll tie this into my next similar topic is peeing while you exercise. So I've been in the CrossFit space for a while. there was a video that went out, I want to say 2012, and there was a competition going on, and one of the top female competitors, it was during deadlifts, I believe, and you could see some urine on the or some liquid, we'll assume it's urine, on the floor right underneath her. She was working hard, deadlifting, double body weight, something like that, for a few reps. So they did a video where they tried to normalize the peeing, because a lot of people pee when they exercise. And again, if you're out there listening, and we'll let you make the statement of whether that's good or not, or acceptable or not. But in that video, they did have an MD who I believe was a urologist, and she was a gynecologist. I don't remember exactly, but she was definitely in the female health spectrum. And she kind of was like, yeah, it's totally normal. Like, and that's what they promoted. And then they had everyone, to make that person feel better, because CrossFit's very community focused. Everyone say like, hey, I pee when I do box jumps, and I pee when I do double unders. And even Rich Froning, who was the fittest man on earth at the time, the champion of the sport, they had, jokingly him say, I pee when I work out too. And again, it was very lighthearted, and I think there was a huge pushback off of that. So that was a long time ago. It was almost a decade ago. So I do think it's come a long way, but also not that far removed from that. So tell us about peeing while you exercise, and what can we be doing to improve, or what should we think about that?
Yeah. Here enters the biggest like quote in the pelvic health world is, an issue like that is common, but not normal.
Mm,
And yeah, I think we normalize stuff like that because it happens to so many people. Like other instances of that, yeah, anyone that's had a kid, or it's like, oh, well, I'm just going to pee when I jump on a trampoline, or, well, sex is going to hurt after you just had a kid the first time you try again, like these things that we are just expected to deal with, but you don't have to. Like, yes, I understand high intensity, high weight exercise, endurance exercise. Yeah, it's putting a lot more strain and asking a lot more of your pelvic floor. But you don't have to pee just because all those people are saying they do. There's just as many people that aren't. And it tells me there is something that could be worked on your mechanics and with your pelvic floor. I'm glad. I think like it used to be very common and untalked about, and I'm glad like even from then a decade ago to now, people are talking about that more. Like there recently was like a marathoner that like pooped herself while running, and she started a whole conversation about how that happens. And gymnasts are coming out about like, wow, you can sometimes see pee flying when they're doing their hardest trick. And so at least we're acknowledging it's a common thing now, but I hope it doesn't switch to trying to normalize it, because it shouldn't. You shouldn't ever have to wear a pad when you exercise because you're afraid of that. Um, and ties nicely into also why like a Kegel's not enough. Do you think a Kegel is going to stop someone from peeing their pants when they're lifting double their body weight? Like you really need a pelvic. And here's a little plug of like what to look for in a good pelvic PT is you really need someone that can match your needs. Like if you are a CrossFitter, you shouldn't be only doing your exercises with a PT on a table. Like you should be lifting. You should be doing more than simply the pelvic floor.
Yeah, and that's one thing I always say, and I love those two things: common but not normal. Something I
Mhm.
talk about all the time, especially as I'm 38, and my classmates from high school, college are all like, oh, I got knee pain, I got back pain. Oh, it's a joke thing, but it's like, yeah, that's not normal. Like you shouldn't be having back pain, and we can do something about it. So same thing here. I love the common but not normal thing for sure. And then yeah, that's the thing I say, and I think I said it when we saw your clinic, Mend. We'll shout out Mend Physical Therapy in Boulder and the Louisville Lafayette area. And I tell a lot of folks, if they don't have a barbell in that clinic, then they probably can't serve you quite as well as we'd like. Because yeah, we should be getting you back to the things you love doing. So if you play with a barbell, for sure, we got to make sure that person can get you there. Unfortunately, a lot of physical therapists can't progress past rubber bands, therabands, and not to disparage the profession too much, but yeah, and again, you pee while you exercise, like, oh, you got to start doing some Kegels, right? That's usually the go-to. I happened to be listening to a podcast yesterday, Jim Jeffries. I don't know about that. Very good podcast. I enjoy. He's a funny guy. They have fun with it. Well, the topic happened to be pregnancy, so it kind of ties in nicely to our other component here. So The guest was the author of What to Expect When You're Expecting, and she has her own podcast of What to Expect When You're Expecting, all that good stuff. Somebody shouted out common but not normal. They like that. Atlas 546. I forgot who that is. Sorry, but I think I know who that is. And so yeah, the Jim Jeffries, What to Expect When Expecting, about pregnancy. She said they were talking about Kegels. The way she described it as the expert is, yeah, just contracting everything down there as if you're holding back some pee. I don't know if you like that cue or not. No, that's a no. You can
to
go
provide
for
a
that.
little rant on that one,
Mhm.
is just a lot of women actually then will do that, and that's the opposite of what you want. You don't want to like stop your flow of urine ever.
Mhm.
One, okay, not good. Are you drawing some urine back up? But mostly just pelvic floor is supposed to be relaxed when you're peeing. And if you're thinking of that or actually practicing that, bad.
Yeah.
Also, little like side note there too, I didn't throw it in my rant with Kegels and the like exercise, like peeing when you exercise. Sometimes it's the opposite of Kegels that you need, like especially these, for example, a gymnast that's peeing herself. Like sometimes your pelvic floor is just too tight and guarded, and then pee
Mhm.
is kind of slipping through these fatigued muscles. So
Yeah.
also why Kegel is not always the answer.
Yeah. And again, we'll for anyone who's either if you're not comfortable with this conversation, I don't know why you're listening. But if you want the analogy or the correlation to something else, so if you have similar tight muscles in your upper trap, and then you have issues with your shoulder, it might be that we need to loosen up certain muscles so that they can function better. So if they're tight, we need to get them working better, right? We need to make them a little looser so that they can work better. Same thing that I think Heather's talking about here. So I like that concept. I like that. So to finish off the Jim Jeffries, I
Mhm.
don't know about that podcast. I can't think of the woman's name right now. The What to Expect When You're Expecting, but yeah. So she was saying throughout pregnancy, yeah, women need to be doing Kegels again to because the effects pregnancy has. And I know you want to touch on pregnancy and postpartum, and there's tons of myths out there. I'm sure anyone who's been an expecting parent has been extremely overwhelmed with the conflicting information and all that. So I'd love to hear from the expert here on the science of what should we be doing with pregnancy, what should we be thinking about, and postpartum. Of course, that's a huge other aspect to it. So
Yeah.
pregnancy.
Yeah, and this is a population where I say like dysfunction or not, every pregnant woman should see a pelvic PT, and definitely every postpartum woman should see a pelvic PT, because even just to decipher all the good and bad information out there, like I've had women come in saying, after I had a baby, I was told I can never do a plank again.
Mm,
Or when I'm pregnant, I was told not to twist or extend or do any bar hangs. Research wise, there is nothing out there a pregnant woman shouldn't do. I will say there is a little bit of lack of research on
mm,
pregnant women, but we haven't deemed anything unsafe. I don't tell women to avoid anything while they're pregnant. The one thing there is some research on, and a lot of even personal trainers will cue pregnant women on, anything where you're bringing a barbell across your belly.
mm,
And it's not the reason you'd expect. It's not that we're afraid it's going to hit a woman's belly and damage baby. It's actually that they found women when they're pregnant, and the really interesting thing, even when they don't know they're pregnant,
mm,
subconsciously protect that area. And
mm.
they were found to hold barbell a little further out to avoid their belly. And then that puts you at risk for other injuries if you're not keeping barbell close. So that was kind of interesting, but that's really the only thing I cue women on. And it's just, but the caveat there, optimizing how you're doing things, because your body is changing when you're pregnant. Yes, you can do everything, but let's make sure you can do a plank without exacerbating a diastasis, or let's make sure you know how to control when you're heavy lifting.
Mhm.
um, so yeah, so to dispel that, and I think, like, again, seeing a pelvic PT will dispel that, and then personalize things a little bit for you,
Yeah.
because it's impossible to make these sweeping, recommendations for pregnant women, because everyone's is a little different. Yeah.
And
And then
that's mhm.
yeah, go ahead.
I was gonna say that's the school of thought I've kind of heard over the years, whether it's old wives' tales or whatever, is just because I've seen women 9 months pregnant running marathons
Mhm.
with no issues theoretically. But it's just the wives' tale being, or the concept being, do what you've been doing. So if you haven't been running marathons, now is not the time to start. But
Mhm.
if you've been running marathons, cool. Like there's no reason you really shouldn't be able to do that. Again, is it the safest thing for the child? It's hard to research that for sure. You're going to go off a lot of anecdotal and scary things. Obviously, that there's a lot of sensitive thoughts around all that. But yeah, that's definitely something interesting to think about there. Yeah, so postpartum for sure, and during pregnancy, is there a trimester that you think every pregnant woman should come see a women's health,
Yeah.
or at that point we can say women's health specialist?
Yeah. In an ideal world, I think even early on in pregnancy to get some of those cues of based on their body, what should they be focusing on? What should they be thinking about when they work out?
Hmm.
But most realistically, I think like at 30 weeks is kind of the prime time of when there's a lot we can work on that a woman's not getting from just going to her OB appointments. Things like how do you actually push out a baby? Like a lot of women, they claim
So
either. Yeah.
yeah, on the podcast, she said basically it's the same feeling of pooping. She said that's how you should be pushing the baby out. Do you agree or disagree with
Well,
that?
the thing I don't like with that is a lot of people don't poop properly.
Hmm.
A majority of people don't know how to
I
properly
think I
poop.
think she said it's like taking the biggest poop you've ever taken in your life is
Yeah.
kind of how she said it. So just like brace and push.
Yeah. But again, yeah, I think not a lot of people know even what
Mm,
that means. And yeah, the push, a lot of people don't get good advice from friends when they ask about, like, well, how do I push? So that's a big thing we go over and even actually feel it. Like, okay, I mean, realistically, pelvic floor needs to get out of the way when you're
right.
giving birth. It's uterus and abdomen pushing. So it's teaching women how to like bulge and
Yeah.
drop their pelvic floor while engaging abdomen.
So yeah, I always come back to this. We talked about prevention. I guess what's coming up for me is thinking about and like a session with a pelvic health specialist. Even if it's out of pocket, if it's just cash, it's going to be under $200 in around most of the country. It might even be
Mhm.
$100. Um, in terms of the impact that's going to have in the ROI, I can't imagine a better investment in your body especially when you're talking about pregnancy, and some of the risks, especially on the female body after in the postpartum phase. So one of the biggest ones is diastasis recti. You said it, diastasis.
Mhm.
I always like the pronunciation of things. But diastasis recti, where again the abdomen will split open, and they measure that how many finger lengths, right? And so is that something you think can be reduced the risk of by having a little more awareness of your body and seeing a pelvic health specialist to again teach you to brace better and things like that.
Yeah. Yeah. So diastasis,
Uh,
and I'll even lump in
Diastasis.
some other postpartum dysfunctions like prolapse,
Hmm.
those two. I really think, and the research again is still emerging in our field. And diastasis is kind of a hot topic right now of like, how are we even testing it? What is most important? But anyway, I am really under the belief, based on the research that's out there and clinical experience, that what you're doing during pregnancy, what you're doing during delivery, and then the really immediate postpartum time frame, I think you can make or break some of these dysfunctions.
Mm,
Well, I don't like to say break. Like I don't think a
right.
woman is responsible if they end up with a diastasis, but I do really think they can help prevent it or do the
Yeah.
best they can with yes how they're doing things during pregnancy. The delivery is key. Like the
Mm,
longer you are pushing because maybe you didn't know the biomechanics of how to push, your
mm,
instance of prolapse is going to increase. How you're lifting your baby after you just had a baby,
mm,
can influence the diastasis.
right.
So yeah, and that's where I think again women are not getting education. So learning from a pelvic PT how to properly do that stuff, I think can be really helpful. And I will say, where there is some research, so France, where they get automatically 10 pelvic PT appointments
Mm,
after they've given birth, their country has way lower instances of pelvic dysfunction and prolapse they
yeah.
looked at. And then the research never got finished due to COVID and things
Mm,
kind of getting thrown out, but I was involved in some research looking at does prepartum physical therapy. So it was just 2 appointments of physical therapy before giving birth. Did it decrease chance of a C-section? Did it decrease tearing? Did it decrease adverse events? And again, never concluded, but I will say we started seeing some good results of
mm.
um, again, more promising birth outcomes and postpartum outcomes.
Yeah, I mean, again, it always makes sense. The same thing if you're going in for a total knee replacement. If you have one or two physical therapy sessions beforehand, it's going to set you up
Mhm.
for success, and you kind of know what to expect and what to do. That's going to maximize your recovery time. So, and obviously, pregnancy or any of these conditions we're talking about here are definitely significant events that we want to know how to recover from and prepare for. So I love that. I'm going to ask you and put you on the spot, and I know you guys have a Pilates studio in your clinic, but I feel, I'm going to throw my bias out here, is that I feel there are a few poor cues, because and a lot of women, in my experience, have gotten their pelvic floor cues from Pilates, yoga. So what's your experience with that? Is it again going to be variable of provider practitioner, in terms of how to learn to breathe and engage the pelvic floor, if you will? Are they doing somewhat more harm than good? Or, again, I don't want to put you too much on the spot, but I'll let you give your thoughts on again Pilates, yoga, and how that impacts any kind of pelvic health.
Yeah. First off, goes back to the like, do women even know how to properly, or men know how to do a contraction or relax? Or are they feeling their pelvic floor move when they're getting these cues? Even if the cue is perfect, and yes, I think that's variable. I will say I've heard decent things when patients tell me what their Pilates instructor or yoga instructor was telling them to do. But again, then it comes down to, are they actually doing the right thing with their body? And
Hmm.
I see countless times I say, and you have to be assessing it internally. And I'll say, like, show me what you've done. And it's like, wow, you're actually bulging out and putting a ton
Hmm.
of pressure through your pelvic floor when you thought you were contracting it, or your breath is so off from what you thought. So I think their advice they give is good. But again, back to that individualized component is, people aren't knowing if they're doing it right, or is that needed for whatever their body might need. Again, if someone has a really hypertonic, tight, guarded pelvic floor, those cues for contracting and engaging it might not be right for them.
Hmm. Hmm.
So, and it's tough. And then back to like, is Pilates super functional? I mean, if that's someone's activity of choice, great. I'm not downplaying Pilates, but that alone is not going to stop you from peeing when you're lifting.
Hmm. Hmm.
Um, so yeah, again, at least it's getting the word out there and getting
Right.
people thinking about their pelvic floor. But yeah, it's not
And
always.
that's and the term I use there is movement practice. And if Pilates is your only movement practice, I think it's still missing things. For some
Mhm.
folks, especially since COVID, Peloton might be their only movement practice, where we would challenge the concept and say, hey, like, make sure you're including other aspects of health, strength, all the ways we can think about fitness. And definitely pelvic floor health, I think, needs to have a place in fitness, for sure. So one other thing that brings me to, again, we're trying to call out all the professions: Pilates, yoga. Next one is, and again, whether it's your own experience, and or the evidence that you can think about, is, when it comes to midwives, home deliveries, any of these other kind of non-traditional uh, aspects of birth, since we're still on that topic. How does that affect? Do you find, again, that kind of, obviously there's all sorts of maybe politics or beliefs around that, but just in terms of what you've seen maybe from uh, folks showing up to ultimately have some dysfunction, is there more coming from those situations than a traditional hospital birth? Is it all kind of the same? Am I kind of chasing whatever that term is? Dark. I don't know what the term I'm looking for is, but yeah, I think you got my question.
Yeah, I will say there is some research out there that, for example, if you have a doula, you're less
Mm,
likely to experience tearing. Don't quote me on this, but I'm pretty sure there is actual research out there that if you see a midwife versus an OB, sometimes your outcomes of avoiding, say, a C-section are a lot greater. Why that goes in, and I often tell people to, if you have a choice, yeah, see a midwife, get some of that more holistic, if you will, care, mainly just because you get more time with them. And
mhm.
I think that's the thing. Like, OBs are busier and don't have as much time to be going over some of this education. And then the other thing of like, okay, a midwife, a home birth, a doula, the only thing in their wheelhouse is a natural vaginal delivery.
Mhm.
Or yes, okay, epidural could be in that, but they try their hardest to make that successful. Whereas an OB knows they can perform a C-section if needed. I think they're quicker to jump to a C-section. And again, don't quote me, but I'm pretty sure that's what the research was, is that a midwife is more likely to hold off before determining if an emergency C-section were needed. And so anyway, so they have more time, they have different backgrounds, that affects your care. As for what I see afterward, honestly, I probably see more patients coming from midwives, birth centers, home births, just because they're more in the know. Like they
Mhm.
actually get the education that they should be going to pelvic floor PT afterward. Whereas, do I see more dysfunction from OBGYN hospital births? Again, they're not coming as much because not all OBs recommend pelvic
Mm.
PT when really everyone should go to pelvic PT. But yeah, I mean, again, anyone that gave birth in a hospital, if they had a C-section, that's a slightly longer recovery. If they had
Yeah.
a vacuum assisted or forceps assisted delivery, that is a lot more trauma on the pelvic floor.
Mhm.
So yes, you can have more dysfunction going and giving birth in hospital-based setting. Um, but yeah, again, I think go with who's going to give you time and attention.
Yeah, definitely. Um, that reminded me of a thing. I see as an orthopedic specialist a lot is C-sections, the scars from the C-section.
Mm.
Um, early in my career, this is something that really stood out and has been present ever since. Is I would get a lot of women showing up with back pain, and again, a lot of back pain for anyone not familiar, or if there's clinicians out there listening. We get a lot of insidious back pain. We don't really know what it is. It's a disorder. It's hard to say. Even if it was like, oh, I was doing a deadlift and I hurt my back, sure, we can kind of say that was a specific thing that led to it. But again, it might be the straw that broke the camel's back. It's not really the true underlying cause and anything like that. And a lot of times, in my experience, I always say back pain is the victim. The low back is the victim. The criminal is somewhere else. So the cause is somewhere else. So, when you have back pain, you have to become a detective presenting in your clinic. And so, a lot of times with women, I just found it consistently that it was like, oh, like there's not a lot of other things going on. Oh, you had a C-section. No one has addressed your scar. No one told you to address your scar. And a lot of times it was like 6 years later, like after their last kid, after their last C-section. And because maybe that's in my really overgeneralized whatever thing is that's when they finally kind of had time to feel it because they stopped running after the kids and they finally were able to shove them off to to pre-K or kindergarten or whatever. And so the question is, yeah, in terms of I assume I know the answer to this. What you're going to say is every woman should be educated about C-sections and scars and how to manage that. But that's something I think, in my experience as an orthopedic specialist, is missing the education around scars. And if I'm the first one educating you about how to manage your scar, and this is years after you've had your C-section, that's not a great assessment of our look for our medical system. So yeah, any thoughts on C-section scars and maybe things to avoid as well in that regard?
Yeah. Yeah, I think it definitely can lead to dysfunctions elsewhere when they're not addressed in kind of two ways. Like the scar itself, I see a ton of, and it can even be years after, if that scar and tissue around it is very restricted, that limits even like lumbar extension. If it's pulling at their scar and uncomfortable at their scar, they're
Mhm.
going to be avoiding that, which can be affecting everything. I've seen just even like really in this, there's a mental emotional component of just totally guarding that area of like some way. I had one patient once, she said 2 years later, she still hasn't touched her scar. She still wears a shirt all the
Mhm.
time. Her husband has never seen the scar.
Mm.
Um, so there's a lot of that restriction guarding. People don't work on it at all because they don't want to, because it's this trauma, because it's marking that event of them giving birth. They don't think it looks good. And then the other thing, though, I think that almost more than the scar itself is just what's lying beneath. So when you're cutting through a lot of things in there, or having this scar and this restriction, women have a really hard time engaging some of those deeper abdominals after. And if they're never trained how to do that after a C-section, yeah, their movement patterns can be thrown off for years and years. So that's kind of second component that can play in. But you're right, they get no education besides the classic, like, don't take a bath for 6 weeks and come back if it's oozing. But I really think mentally, emotionally, and physically, women should be working on that scar. I even have some women like indirectly mobilizing the area like a week out. And then, of course, once it's like that 6 week things are cleared, like definitely mobilizing that scar.
Yeah. Yeah.
Yeah.
Awesome. And then I definitely want to touch on this, and I want to be respectful of your time. I know you got to go soon, but men's pelvic health,
Mm.
just generalities around that. And I would encourage folks, and I'll put a link below, episode 38 of Bono stuff, with Dr. Laura McCaig over in Kansas. She's she one of her specialties is men's health, men's pelvic health. So what should men know? How do we break down these taboos? Hopefully we've done a good job so far. And is there anything, again, men should just say, oh, like, again, is it, is it at age 40, I think, you get your first prostate exam? Or is that the time that, again, we should be checking in and this, or should we be doing this sooner? Should every man, any age, again, be getting this information? Go.
Yeah. So yeah, I think again, men really don't talk about this stuff, and they think pelvic floor dysfunction is just for women. Or that image of, yeah, like pelvic floor therapy is only for old men after you got a prostate removed. But I will say in my practice, and again, like I'm in Boulder, people talk about these things more. But majority of my male patients are younger, like, in their 30s or below. It's not only these old men with prostates. And what I see most of, and again, it's different where you are, but things can go wrong with, there's pudendal nerve innervates pelvic floor, and can get irritated from a number of things. The biggest one, they call it like cyclist syndrome. Sitting on a bike seat for extended amounts of time can irritate that. I've even seen it in CrossFit population, endurance athletes. Nerves get irritated, muscles get tight, and men don't realize that they can address it physically. And it's symptoms like a numbness or tingling. Which again, some people tell you is normal. Like, oh, when you go for a long bike ride, yeah, your testicles are going to be a little numb after. Not normal though. So any numbness, tingling, even things that, again, you might think are more the medical route, but like erectile dysfunction. I've had so much success treating people for erectile dysfunction by just looking at their pelvic floor. So yeah, a wide range of things we can treat with men, any sexual dysfunctions, any incontinences. Yeah. And again, it's for young men as well. Obviously, they don't have something like getting pregnant and being postpartum that they should like routinely being checked in with pelvic floor health, but definitely when anything goes wrong.
Awesome. Well, yeah, thank you so much for your time today. I'm going to let you go. So let's wrap up with asking, where can folks connect with you, find you? What other resources do you want to leave folks with?
Yeah, cool. So I am in Boulder at Mend Physical Therapy. Yes, we have a location in Louisville, Lafayette area. But yeah, I mean, anyone in the pelvic health world, like, I'm just passionate about this. You can reach out to me and I can answer any questions, even if you're not in Boulder and in Colorado. I guess a good way to contact me, my email is just heather@mendcolorado.com for any questions.
Awesome. We'll put that in the show notes, if anyone wants to reach out, or you can always reach out to me and I can get you in touch. And thank you, Heather, for your time. We will sign off, and hopefully you all got 1% better today, if not 10% or 20%.